Everyone at Einstein's Eyes, our YouTube channel. I'm Carl Rosen, oculoplastics, neuro-ophthalmology in Anchorage, Alaska. My partner in crime is Jon Ditkoff. Jon, go ahead.
Oh, hey. Hello, good evening, everyone. I'm coming to you from New Jersey. I'm a general ophthalmologist who specializes in cornea. Carl and I have known each other for many years. We both trained at Einstein Eyes, or Albert Einstein, hence Einstein Eyes.
Right.
And now Carl is our new information technology expert. It's an
Right.
inside joke, sorry for you guys out
Right,
there.
right.
And I'm really glad to see Chad again and make our YouTube site much more interesting, bringing him on.
Right.
Yeah.
So today we're going to talk about geographic atrophy and macular degeneration. And we brought Chad back because he did such a great job. He's our local image or vision of Superman. We just want to say that. Chad was an Army major. Thank you for your service, Chad.
Yeah.
And Chad's did a fellowship in retina, and he is local here. And I'll let Chad say hello. And I do want to say that we are going to talk about Syfovre, which is the injectable medication for geographic atrophy that is based on inhibiting complement components that is part of the immune system that typically affects bacterial lysis or a part of the immune system that defends against bacterial invasion. Chad?
I'm going to point out after that short soliloquy by Dr. Rosen that there's a reason we brought Chad on today, because we've been getting some feedback from our followers that we're getting boring. And Carl just hit a new high on that. And we wanted someone that was a better looking guy to make this video more interesting. So take it away.
All right. So everyone hit that button to like and subscribe.
Yeah.
So my name is Chad Bouchard. I'm a retina specialist in Anchorage, Alaska. Yeah, thanks for having me back here today to talk about a completely new revolutionary medication for dry macular degeneration. So we've had patients for years asking, when is dry macular degeneration? When can we treat that? Aside from just eye vitamins and observation. And finally, something is here. It's particularly for the more advanced form of macular degeneration where we see atrophy, and we call it geographic atrophy. And I think Carl has a photo that we're going to be able to show. So here's a photo. This is what I look at many, many times each day. And those white patches, that's complete tissue loss. So we call that atrophy. And when it's very big like that, it's called geographic atrophy. So this photo, this patient is the perfect candidate for this new medication because the center part of the vision, which is highlighted that kind of darker area, is called the fovea. That's our 20/20 center that we want to preserve. And patients with this kind of macular degeneration, they have this profound loss of vision and involving the center of the vision. Now, this patient, it's kind of circumferential. And so the rate of tissue loss that occurs, it's about 0.5 millimeters squared per year. So it gets bigger and bigger and bigger. Every year we see these patients, we scroll through old photos and we see it started out with one little dot and then got larger and larger and larger. And the idea with this medication is simply just to pump the brakes. It doesn't reverse anything. It is not stem cells. It doesn't bring the tissue back, but it just slows things down. So it enhances, that prolongs the quality of life, the ability for these people to see. And we just got 3-year data that came out. And the amazing thing with this drug is the longer that you're on it, the better it works, which is incredible. So it can slow things down. The 2-year data showed that at every other month dosing, it slowed it down 21%, which is pretty impressive. The 3-year data every other month showed a reduction or a slowing down 28%.
So that's awesome. So Chad, let me just jump in. So again, just for our audience, these whitish areas, you're seeing something called a choroid. So the retina, and there are a bunch of layers to the retina, 12 layers to the retina. It gets destroyed by geographic atrophy and macular degeneration, the dry variety, not the wet variety.
Mm-hmm.
And what you're saying is Syfovre, which is this medicine that stops complement from damaging the retina, prevents photoreceptor loss and expansion and creep of these white patches, right?
Exactly. Exactly. And this photo here, this is the ideal patient to where we still have some center involving vision left over, and we want to preserve that. And there's a variety of different inclusion criteria and who would be a good candidate, but this is the ideal candidate. I'm glad you brought up the wet form, and I highlighted every other month dosing because it's something that I do in particular. And the reason why I choose to do every other month dosing is, again, going back to the studies, every month dosing, which is an option, has shown that there's a slight increased risk in converting the dry macular to wet macular. And so I choose to do it every other month. My colleagues choose to do every other month. And it's a little bit, I feel, kind of safer in that idea. And then one thing to point out too is that this medication is essentially given indefinitely. So it could be 20, 30 years left of this patient's life, and they're getting it for that long.
Yeah, let's just
So
show
there's
the,
definitely less burden at every other month.
and here's the medication, Syfovre.
Yep,
Here's the bottle where the medication comes in and you draw it out and you inject it into the eye.
that's
And,
right.
and Chad, just to highlight for the audience, you can get infections called endophthalmitis,
You
and you
can.
can raise the pressure with this medication because,
You-
as you pointed out, this
Mhm.
medication is very thick, right?
It's very thick. It's like corn syrup. It's very, very thick. And it's given, in fact, at double the volume that we normally give. So we normally give, for wet macular degeneration, we give 0.05 cc's, incredibly small amount into the eye. This is given at 0.1, so it's twice the amount. So it can cause vision to go dark for a short period of time because the pressure does go up inside the eye. It's a contained space. You mentioned infection risk, so we call it endophthalmitis. So the what I tell patients, and the overall average is about 1 out of every 5,000. So despite our best efforts, it can still happen. We clean the eye, we do all necessary precautions, but it can still happen. And it's a dreaded consequence. And so that's another reason why we want to overexpose patients. We choose the right candidates for these treatments at the right dosing interval. That's very important.
That's beautiful. Yeah.
So I have a question. I have some patients similar to that picture you just showed that have very good vision, 20/25, even
Mhm.
20/20 potentially. Are they still candidates, even if they have very good vision, or is there a criteria?
Absolutely. Yeah, those are in fact the very
That's the
perfect
idea.
candidates. Yeah, where they have noticeable geographic atrophy that's not involving the center. And most of those cases, I would say, or a very large amount of those cases, they've already had the other eye completely wiped out by either geographic atrophy or wet macular degeneration. So
Mhm.
that 20/20 eye, that's all they have left. So that is the ideal patient to choose this medication for.
Yeah.
And what
That's
about
great.
costs, like insurance? Are insurance companies covering this now?
They are, fortunately, they are covering, and there's even programs that exist to help with copays called Good Days programs, where these pharmaceutical companies have some assistance to help with patients who don't have a secondary insurance. But all major carriers cover this, and we're very fortunate to have it.
That's great. That's great. John, can you think of anything else?
Yeah, I mean, to me, it's great because I've been hearing, to be blunt, as an ophthalmologist with almost 30 years of experience, first time I think I heard about this was we have a Henry Winkler commercial. Do you guys hear that in Alaska? Or no, do you hear those commercials?
I've had so many patients say, "Well, what's that stuff that this?" And I was like, "Well, no, I'm literally drawing it up, and I'm about to and I had
Yeah,
to remind them, that
not to
it's called
talk.
this, even though despite the fact they may have gotten several treatments already, they just sort of forget. And
Yeah, so I think the
yeah,
advertising, I had a lot of patients ask me about it. I have to admit, in Northern New Jersey, I don't get the impression that, I guess the question, is it's a 30% on this recent data. That's the really
yeah,
good news.
hmm
Is it 30% of patients are responding, or is that 30% of all patients, there's 30% reduction, less reduction?
reduction. So slowing
That's
it
across the
down by
board.
that amount.
So almost everybody's getting a response, but
Yes,
at 30%. So in a
yeah.
And
perfect
that,
world, it would be stopping it dead in its tracks, but 30% is great. Yeah.
that's what they had to present to the clinical trials, that the geographic atrophy, the progression within the retina, the eating up of the retinal photoreceptors
Mhm.
and the RPE cells and the rest of the retina is slowed down. So it's like water spreading out. It doesn't spread out as fast,
Mhm.
you know?
But
Exactly.
that's across the board. I mean, there are some patients that don't respond, or everybody responds.
So everyone really that was in the study, everybody responds. And so
Wow,
the right inclusion criteria.
Sure.
And the challenging thing is, of course, people, patients come in and we show them photos and they're looking. So how can I tell there's a difference? Well, you really won't be able to tell very much, right? Because this is so minute and at the cellular level. And we can, if we had day 1 to, let's see, day 400 or something, we'll be able to show them, but only after 4 or 5 treatments, neither of us can really see that significant, but there is a definite reduction. It does slow it down.
And in the study, did they use photos, exam, Mac OCT?
That's a great question. So autofluorescence is the
Standard.
imaging system that looks at the deeper level of the retina, and that's the one that you want to use in order to guide your treatment.
Interesting.
That's great. So
Yeah.
Chad, thank you for that discussion. That was really interesting. I think I learned something. John, I think
I learned a
we
lot.
both, yeah, we both did it. Particularly not, since I'm not a retina specialist, it's nice to hear about this. But something different in the channel I wanted to start is a save of the day. What was the biggest win today or the biggest success that you had either in the clinic or in the operating room?
Yeah.
Go ahead, Chad.
That's a good question. And my very last patient today, it's an unfortunate scenario. So the patient is deaf, lives in an assisted living facility. Very hard for these people to communicate. And he was referred in for a condition called retinoschisis. And so that's just kind of a splitting of the layers of the retina. And it's pretty common. About 7% of the population have it. When I was looking at evaluating the patient, so it's actually not schisis, it's actually a retinal detachment. And the center of the vision is still preserved. And so what I found particularly unique about this situation is, and of course we have him scheduled for surgery, but the particularly unique about this situation is that, the patients such as him are disabled and they can't communicate that they can't see. They can't communicate that he has a curtain of black up here because not everyone has the ability to sign. And I found it very special that I was able to be a part of his care, and hopefully surgery goes well and we'll be able to give him his vision back.
That's great, Chad.
Superior or inferior?
It was an inferior detachment.
Yeah, that's good.
Yeah,
So that means that the inferior visual field is affected.
exactly.
And just for our audience, the eye is peculiar in that it's opposite of what you expect. That's just the way the brain is wired. Hey, guys, thanks for showing up. I know it's a Monday after work. Chad, you're a beast.
Thanks for having me.
Stay strong. And John, I'll see you on the next one. Chad, we're gonna have you back for more discussions about retinal issues, retinal surgery, and just
Great. Looking forward to it.
Feel good stories, Chad. Keep them coming.
All right. Thanks for having me.
Have a great
All
night.
All right.
Thanks, guys.
Thank you.
Bye.